am proud to announce
Mr. Hegde, another of the bearers of this association, and my colleagues, elders, and students. I think he left a very important aspect of my life story. I am a student of National High School 69 years ago. And they made me a chief guest on the 99th year of the high school existence of the day. Since then, I was close to Dr. Maiya, who was living next door here in the hostel. Though he was not my teacher, but still, because I didn't study in the college here, I was only a student of the high school. So, but we are very close in various social activities since then. And then the year when I joined this college, the year of independence. Even midnight speech of Jawaharlal Nehru used to hear in the open space here. And Dr. Maiya was very particular. I give talks. I was away, since then I was away in England and then came back and posted to Boon, that side. When I came to Bangalore in 1975, first thing he asked me is to give a talk on the Science Forum, which was held somewhere there. And the first topic I selected was drugs, disease, doctors, and devils. Anyway, I used to follow his order. He used to say, this time English and Matarapa, next time Kannada Matarapa, third time mix both and talk. So I used to talk as he likes. But this time nobody to guide me. I said I speak because high technology talk, so I speak in English. Now this subject I selected because for 40 lectures I have completed most of the medical diseases. I think 2 years ago I gave a lot of dengue and chikungunya, etc. I said mosquito and fever. What else to do? So I thought this time I would take high technology. And you know, about 100 years ago or 75 years ago, patient was more often cared for than cured. Then we did not have antibiotics, machineries to treat and cure the patient. What is important, caring the patient. Now with this technology, we have forgotten caring the patient and only thought of curing the patient. That is the cause of most of the problems on attacks on nursing home, hospitals and all that. So both care and cure has to go together. Anyway, over the years, 75 years or so, a tremendous development in the medical science. Though medicine is both science and art, but it is science which has developed over the 75 years. Tremendous development. For example, to give you an example, you see complete heart block. That means patients with a pulse rate of 30, 40, 50 like that. That means the electricity of the heart is damaged or blocked. So you see the heart contracts only 40, 50 times. Nothing may happen. Even I am told Napoleon Bonaparte had a congenital heart block that was with a pulse rate of 45. You know, he fought with British 7 times and then got caught anyway. So it is not that they have to be bad, but if the block is quite low, they can go into a cardiac arrest, etc. And so, what is the treatment? A natural course and pray God. So natural course of the treatment there. But in 1950, now we have pacemakers. I suppose you know, when I say block, it is not the vessel block. I am talking of the electricity wire block. So they have a pacemaker sometimes below the clavicle. Check the next ischemic heart disease, that is coronary heart disease, If the patient had a chest pain, cardiac pain, we used to give them sorbitol, keep it below the curve, pain disappears. You are happy with that with some drugs, this aspirin, etc. But now we have bypass surgery is available in 1960 onward, and stenting, you hear everywhere, stenting is available. So also renal failure. Renal failure, patients used to come with anemia, vomiting, loss of appetite, loss of weight, etc. If it is loss of appetite, you give something for the appetite. Loss of weight, make him eat. So nothing else you are going to do. Passive treatment. Now we have a dialysis, we have a transplant. With that, the patient can have almost a normal health, at least 5 to 10 years. So you see this tremendous development over the years. Now, so you find the lifespan in India, everywhere in the world, has increased. Then, this gentleman, Ivan Ilek, said, no, it is not the high-tech medicine which is responsible for the increase in the lifespan. He said, it is because of the sanitation, better living standard, that is the cause of the increase in lifespan, not this high-tech medicine which serves only few people. So he was against this high-tech medicine. Now, what is this? So you have some benefits from high technology, some definite benefit from sanitation, etc. So what is it we have to know? What is the actual problem with high technology? Why is it not so beneficial? Why sometimes it's not so beneficial? So, to understand this, let us know what is high technology. It is difficult to define, but some of the characteristics, if I can tell, they are very complex ones. As you see, when you see a patient with too many wires around his body, it's a very complex one. You don't know which wire goes which side. So catheter one side and wedge to the other side. You don't know. Tube through the nose, tube to this one, tube to this one. So you can see that picture I put. So it's all complex. And it is expensive, naturally. Expensive. And there is a high demand but low availability. And it is dynamic. What is high technology today may not be high technology tomorrow. That also you must know. And it's always control specialized staff, people who know this high technology. To give some examples, imaging is one. I will go into details later on, CT scan, MRI, etc. And intensive care units, there's all high technology. You see a patient covered with all wires there. And lab test of biotechnology, etc. and genetics, etc. And then you have a transplant dialysis, that's high technology. Surgery, now you have got a robotic surgery is coming in. So that is also. And digital technology, most of you know, is used in every field, and it's also useful in the medical field. I cannot discuss all these things within 45 minutes or so. Digital technology, you know, and one of the hospital records can be kept very well computerized, and you can keep the record for years together. And if you have an X-ray or ECG and the consultant is not available, you can send this ECG and X-ray to him, so you get the report. So digital technology is a very useful thing. So it's high technology, useful for us. Now let us go into the CT scan. Few examples when you will be able to discuss. The point you have to know, about 75 years ago, the X-ray was found. After that, no further improvement. It is in 1972, Dr. Hansfield is a doctor and a physicist is a coroner. They were able to discover this CT scan and they won the Nobel Prize for that. Until that time, you are not able to image the brain. Brain means you can only take a skull X-ray. Skull X-ray is available. What is inside the skull? Nobody knew. How to know at that time how we used to make any brain tumor or anything? Then we used to inject dye here and that goes to the brain. Brain vessels, if they are distorted, then we know there could be a mass here or tumor here. Or if there is a block to that, oh, this could be a block. Indirect evidence of a mass in the brain in there, but you could not get the brain itself. Now, with this CT scan, brain is imaged directly and procedure is non-invasive without troubling the patient. And so it helps in the diagnosis of infarction. Infarction is blood supply to the area of the brain has gone, stroke. They come with stroke, you take a CT scan, you have an area of damage you can make out straight away. Hematoma, blood clots you can make out. Earlier you used to make out indirectly, not by blood. Now you can see the blood. And tumor, and also swelling of the brain in certain diseases, you can make out. Then there is an MRI, modification of the CT scan, you can see the spine very well. In older days, we used to do a myelogram, that we used to inject a dye and see what has happened to the spine. Now, if you do an MRI, you can make out a tumor there, any disc lesions there, everything can be made out by simple MRI, like trauma, spinal sclerosis, tumors, etc. So also if you take a chest X-ray may suggest a mass, sometimes difficult to make out. You have a CT scan, you can make out the tumor and where it is spread and all that they will show you. And then you want to take a biopsy, with a CT scan, but a guided biopsy, where the tumor is, you can put a needle and take a biopsy. So it's a very great benefit to the medical science. This is a CT scan and MRI, that's how the patient gets in. And you can see there are some of the pictures. There you can see this is a tumor in the brain. So you can visualize the brain itself. We had no means to visualize the brain for so many years. Now you can visualize the brain. This is a tumor. You can see a low hypodense area. This is an area of infarct, that is the blood supply to this area. So he has got, if it is on the left, right side, stroke is there. This is bleeding. You can see these two are the hemorrhages, brain hemorrhages. You can see further area of hypodense area where these are all strokes. And this is the lung where you can see a tumor here, number of tumors, secondaries in the lung, you can see. Now, if you take the abdomen, see this is the liver. This small area, hypodense area, is a tumor in the liver. We had no means to know all these things. So you can do it just taking an X-ray. And this is the lung. There is a mass here. If it is a mass, we don't know what is that mass. You have to have a biopsy. You have a needle guided, CT guided biopsy. The biopsy can be made. And you can see this is the spine. This is the vertebra. There is a tumor there. You can take a biopsy, MRI guided. Here you can see also a liver where you can take a biopsy. So you can take a biopsy, you can recognize the mass, everything you can see as it is. Now this is a very useful, very helpful investigations we have, high-tech medicine. But the problem is what is the burden we have now. One is the cost. Anything 3,000 to 5,000 you will have. The cost of this one in a multi-speciality hospital or this one corporate hospital, it may be little more than usual. So high cost is one. But when you use this, you must use it appropriately. Then this cost is not the point. But unfortunately, there is an inappropriate use of this CT scan. These are the causes, inappropriate tests. Routine test for headache. I was just talking. If somebody goes headache, patient talks, sir, CT scan will be solved. If the patient doesn't tell, his relation will tell. Otherwise, doctor will tell. So you have routine test for headache.
Suppose only a few days ago, a patient 15 days fever with headache came to me, and the patient had fever. Whenever he had fever, he had headache. It's a normal thing. But he was worried, headache, which is there, something else is there. Or something else is there, something else is there. So the fear of the patient, you are forced to ask for a CT scan. Sometimes doctors fear, he will ask for a CT scan. Goes away. And had a CT scan somewhere else, and he came to me. Then, before I asked him, what is your problem? Sir, CT scan notice, sir, CT scan notice. He was more worried about showing a CT scan than telling his story. And you know, 85% were diagnosed made by patient's history. 85% is made by patient's history. That is why we always tell, God has given one tongue, 2 ears. You listen to patient twice, talk only once. That is, patient will tell the diagnosis. But we forget that the patient is also worried. You use particular expense of money, so you have to see the CT scan. So I told him, wait, you tell your story. Then, when I asked him the question, he said, whenever he has that fever, high fever, 100 to 103, he gets a headache. I said, that is the cause of headache. All right, you have spent some money, I see this CT scan. What does CT scan shows? I said, this shows you have got brain inside. So, the diagnosis is typhoid fever. Due to fever, he had a headache. So, that is what is the diagnosis. So, this is what is called inappropriate routine test for headache. Then you have a lot of psychiatry illness, dementia, loss of memory, etc. People come and CT scan because they are worried something else may be there. So, either doctor will tell or the patient will. Doctor tells for various reasons. That comes that later. So, psychiatry, dementia. But when there is a loss of memory without neurodeficit, that is, without a weakness in one side or some neurological disturbance, I don't think we should ask for a CT scan. If there is a neurological with the loss of memory, then there could be something. So you have to ask for a CT scan. Now, encephalopathy. This is very important. If the sugar is low, you get confusion. If it is still low, you become coma. Hypoglycemia, low sugar coma. Now, people, because it is a coma, they ask for CT scan. It is foolish because you check the blood sugar, give the glucose, will be all right. So, that is one thing. Second is hepatic. You know, Kamle jaundice. A jaundice can affect the brain. So, you have a hepatic encephalopathy. That is, brain involvement in a jaundice case. So, it is obvious. Jaundice, liver disease is the cause of this. What is the point in taking? Because he has got brain involvement, you take a CT scan, it does not show anything. But the treatment is for the liver disease. So, that is hepatic encephalopathy. So, uremia, kidney failure, you get a brain involvement. For that, you need not take a CT scan for that. So, all these are inappropriate use. And sometimes, insistence by patients and the relatives due to fear, or sometimes ego. Yes, sir, ನಾನು CT scan ಮಾಡ್ಕೊಂಡು ಬಂದ್ಬಿಟ್ಟಿದೆ ಅಂತ ರೋಪಾಗಿ ಹೇಳ್ಬಿಡ್ತಾನೆ. So ego, patient's ego. This used to be so, before CT scan was available so much. I remember years ago it was only available in Madras. Sir, Madras ಹೋಗಿ ಒಂದು CT scan ಮಾಡ್ಕೊಂಡು. That was his first, before telling what is his problem. So, that ego. And then, doctor's problem. Super specialist ego. A super special thing, nothing should go without a diagnosis. Even if 1 in million cause for it. Suppose you say most likely it is nothing there in the brain. But there could be a chance 1 in a million. He doesn't want to miss. Oh, he doctor is responsible. That super specialist ego. And the last one is known everywhere. You kick back everything. That if you order a CT scan, some percentage is given to you. And the more CT scan, even the corporate hospital, how does the judge the doctor? Doctor is judged by his relationship with the patient, his communication skill, and how kind he is, and how proficient he is. He should be judged like that. But in a corporate hospital, many of these hospitals, MBS judge you. How do they judge? How much money he gets into the hospital? How does he get his money? Either more investigation, more CT scans. So that is the plan. That is commercial. So these are all the inappropriate use of the CT scan. Next. So this inappropriate use. But it is useful, CT scan is a useful thing, but inappropriate use we should be able to control. Then next we go to a second part, intensive care units. This is another thing. So the patient says, sir, patient is in ICU, sir. Why is in ICU? That is the problem. Now intensive care, this is the picture. You can see number of wires, number of instruments, etc. The intensive care. Now, in the intensive care, various technologies are used. That is for breathing, for heartbeat, for brain circulation. Various technologies are used to treat a very ill patient. To treat a very ill patient has to be observed carefully and treated with many technologies. And you need specialists, not only doctor, specialized nurses and etc. and others. And who are the patient? Not if you have 100 patients, there may be 3 or 4 who need an intensive care. Who are there? With chest injuries, neurosurgery, heart attack. So these patients need an ICU care. And ICU does not mean it's only a treatment. It's an intensive care by doctors and nurses, observation. They suddenly pulse rate can go to 200, that they would be able to catch with the monitor. So that is why intensive care doesn't mean intensive treatment only, it is the intensive observation of the patients. For whom it is useful? Very ill patients, there is no doubt. But whom for it not useful? That is where the problem starts. In some of the, now if the patient is too ill with unacceptable quality of life, what is unacceptable quality? There is a relative term. Patient is brain dead, unconscious, years together. Some 90, 100 years, they've got kidney failure, heart failure, so many failures. Even if they recover, they cannot be normal. Such are too ill, unacceptable. Even if he recovers, he has to be bedridden. Such are unacceptable. This is a very deep term. We have to discuss with the relations. That probably they do not need. But patients who are admitted for observation, post-operative and all that, it is also no benefits for the ICU. But sometimes we admit people for ICU if there are too much problem with these relatives. They come and ask you 100 questions and they ask you, sir, he needs a lot to, so many questions they ask, we have problems. It's difficult, you can answer to a certain extent you can't answer. So then you push them to ICU. So ICU means you always regulate their admission, entry, etc. So you are safer, you are more comfortable. But I think it costs money for the patient. So further, lot of invasive procedure has to be done. You have to have a tube itself or breathing trouble, and a lot of injections, etc. Invasive procedures are too many. And then you have to go on investigating morning, evening, because patient is very ill and patient has got social deprivation. He feels, I'm alone, nobody is there. If he is in the ward, so many are there, they get chit-chat and all that. But in the image, we have to only look at the monitor, look at the grim face of doctors and nurses. So naturally, so he gets social deprivation. And cost does matter. It costs about 4 to 5 times more than a general ward or a special ward. Then the question comes, ethical issues comes. Now, if you admit a patient for resuscitation, very ill brain dead patient, is it correct to admit them to ICU? To prevent some problems, we put them to ICU. But ethically, is it correct? If we do it, brain death is there, is it correct? These are bigger questions, needs one lecture only. Whether you must prolong their life. There are 2 types of euthanasia. Euthanasia is mercy killing. One is you kill the patient by giving some blood. So active mercy killing. Other is passive mercy killing. Passive euthanasia. Active is not allowed. Even passive is allowed in one country in Europe, in Holland also, and few states in states. Because euthanasia in India, passive or active, is not legally allowed because it can be abused or misused. You can kill anybody. You don't know that. Because doctors also from society. You don't know what. So it is not whether, but I think you can discuss with the patient's relations whether is it worth continuing and all. At least passive euthanasia, without naming it, can carry on. You can take off the oxygen and other things. And if the patient is, if after discussion with the patient's relations. Now we go to the another aspect, coronary artery disease. That's heart attacks in the common term. It manifests as chest pain, heart attack, heart block, and what is the drug we are giving? Drugs we are giving, and then bypass operation, you know, and then stent everywhere. All these things are being done. Now, this is bypass procedure. But it's bypass like a road bypass, nothing more. You can see here, here is a block vessel. This is the vessel of the heart. This is blocked. So the ultimately blood supply should go to the muscle. How that if it is blocked, blood will not go. So you take a vessel from somewhere else, you connect it here this time. Take a bypass road. So blood supply, that's called bypass surgery. So also they take a vessel from here, connect from this vessel to this top here, then the muscle is supplied by the blood. Now what is the benefit? This bypass operation, what is the benefit? Nearly 1,05,000 is done in 2014 in India. 1,50,000, 1,50,000 CABG, coronary artery bypass surgery. It started in 1960, is being done. And definitely, when you give drug, pain all disappears. But in some of the cases, it won't disappear. Then this does have drugs fail to control. And there are some main vessels, left main vessel, or three vessels. If they are blocked, then this bypass is useful. And though it's a heart surgery, mortality is very low. And 90% of the patient live for 5 years, and nearly 80% about 10 years they live. So in that way, this bypass surgery, which is initiated in the 1960, is a useful surgery. But remember, it doesn't cure the disease. People think, I had a bypass, so I'm all right. No. You are only bypassing the date of murder. Date of death. So you are only bypassing it. You are not curing the disease. Curing the disease is by controlling the risk factor, control of diabetes, control of hypertension, control and some of the aspirin-like drugs to avoid clots, etc. That is what is done. So weight loss, weight reduction, etc. Those are preventive treatments. And this only palliative, and reocclusion may occur. After 10 years, 50% will have, it can be occluded again. There's one study where 11 years, nearly 60% only it was patent. So it is only a bypass. It is not a cure, that you must know. Even if you put stent, you must know it is not a cure. Now, the cost surgery is not so much, but anyway it is there. It is done everywhere. Proper, now we have to select only few cases are good for bypass, that is main vessel, three vessels, etc. Failure of medical therapy is useful. Then from 1979 onwards, you have got these stents. It is not stunt, it is stent. Sometimes doctors do a stunt. Even in the States, 30% unnecessarily done. But it is a stent. What is that stent? You can see this stent. These stents are put where blocked vessel. First you dilate the vessel by a balloon, and then put the stent. This could be metallic stent, it could be drug-induced stent, or it could be sometimes human tissues. There are 3 types of stents are there. And this, you can understand in 2014 that 5 lakhs people with stents in 140 cardiac centers in India. That means it is getting popular so much. 20% increase every year in stenting. Earlier to this, we used to give an injection of certain drugs which would dissolve the clot, but it's only 60% success. But with this, if you are doing it within 2 years, it is quite a good number of success, 90%. Success in revascularization. That doesn't mean it doesn't clot again. So it is not a cure again. It can clot again, re-thrombosis can occur. But remember, stenting is a very popular thing, and they stay in the hospital 24 to 48 hours. And the cost naturally 2 lakhs, 3 lakhs, depending on your status and whether you are an insured person or not. You know, the hospitals, if you they will ask, are you insured? If you are uninsured, your rate is different. So that is always right. So insurance plays a great part in all these things. So that is it. But you must know its limits. The availability, see, you must, if you go within 2 hours, then it is possible. Many times with Bangalore traffic, you cannot reach the hospital within 2 hours. So it must be a cath lab that not all hospitals can do. That catheter is done, it can be done, and doctor must be available in it. And it's used only when 1 or 2 vessels are blocked. If there are 3 vessels are not possible, and the cost of procedure 2 lakhs, 3 lakhs, 4 lakhs, and stent thrombosis may occur. That is clot again. See, all these are palliative surgery. Don't go with, I do not discourage people who are stent. Understand? So, stent, no use, it will be re-thrombosed, that. Don't get depressed. But that has saved you. It may be all right later on. But remember, it's not a cure. If you are a smoker, stop smoking. That is a cure. That prevents the disease. But it takes years, you must know. So, preventive therapy is still important. But immediately, circulation is maintained. So, you find coronary artery disease, high tech is only CABG, that is the operation, other is stenting. They are useful, definitely. Time to balloon, time to door type. Balloon to door type. That is, by the time doctor ends the balloon, and by the time you arrive, it must be about 2 hours. By the time you go from the traffic and all that, then it is successful. Successful to clear that vessel. It is only palliative, you must remember that. Now we go to the next one, renal replacement therapy. You can see this is a renal transplant, dialysis. You know the extra kidney, these are the 2 kidneys. This kidney is failed, and this is your extra kidney which is working. So this is renal transplant. Now, you must know this is a very common disease. Nearly, you must know, 150 to 250 people per million in India has got end-stage renal disease. Kidney failure, end-stage renal disease. They cannot be cured. Only 150 to 250 per million in India. And the renal transplant is the answer. Dialysis is to go on. Sometimes you cannot do it. India, 19 Bangalore, they are the first one to do this. And India has 160 transplant centers. Here also have plenty of transplant centers. And you have got 2 types of donors. One relations and living donor. Other is the deceased donors. Cadaveric we call them. Now, what is the benefit? What is useful? See, this has definitely revolutionized the outcome of chronic renal failure. Earlier, as I told you, we used to allow them to die with only symptomatic treatment. headache, anemia, some blood. Like that we used to carry on. But they are not normal. Now, this is revolutionary and good quality of life, and nearly 75% of people live up to 5 years, nearly 55, even I think up to 90% go into 5 to 10 years. Quality of life is almost normal. So that is why it is a very useful high-tech medicine. Only limitation is availability of the kidney. You know, you got the kidney business used to be there. That there are agencies who pick up people, poor people, ask them to give the kidney, and they get money, and the agent also gets some share. Sometimes agent share is more than the poor man's share. So those things are there. So that made law a little strict, and you got transplant committee. You have to go through that committee, all this time. In spite of that, so in a company, the boss gets the kidney from a worker. Those are no financial benefit, but definitely, financial benefit is there, or at least a promotion would be there. So that will be there. So it's a little difficult thing, but anyway, it depends on the other, right? Cadaver kidney is not yet popular. That means if somebody dies, brain death or anything, or patients who are likely to have brain death, they have a list of them, and within certain period, you can transplant kidney. That is used for cadaver. But it's not yet popular, but even then, the amount of cadaver is much less. And the problem with this cost of, one is the transplant itself may not be very costly. It is cheaper in India. That's why we get a lot of people from Nigeria, Africa, etc. Even America, they come here and get a kidney transplant. Earlier, I used to see they used to get kidney from here only, kidney business. But now, I think they get somebody from Nigeria and their relations or something, and they get transplant. But the problem is, they have to be constantly on drug therapy, which will come to about 10,000 rupees per month, 10 to 15,000. That would be the cost for a poor man. That is the thing. So, I don't think I'll give any more examples, but let us know what is the attitudes of the patient and relatives for the high-tech medicine. What is the attitude? Patient relatives feel they must get this high technology help. I mean, everybody agrees. However poor they feel they should have this. And but they are worried about the cost. Second, some people is a prestige issue. They are telling, we want to go transplant, not going to go. So he feels bad. So it's a prestige issue. And some people feel high technology distances the doctor. Suppose you might be seeing the modern doctors sometimes go to ICU, look at the monitor. So pulse rate is 70, BP is so much, oxygen saturation is so much. Very good. Sister, do all these things and go away. Patient will be looking at the doctor, the way he looks at me also. The patient gets disappointed that he doesn't look at it. If you see someone, the oldest physician, I know in a Victoria hospital, I don't name them, but anyway, one of the oldest physicians, he used to examine the patient with the stethoscope here, Inappropriate, Agidya, like I mentioned, Brown, the oldest physician of Karnataka. Inappropriate, Agidya. Patients are so ugly, but this is here only. So also, feel the pulse on the wrong side, but patients are happy. That's why medicine is not only science, but it's an art. 50% of your cure rate is how you talk to it, how you communicate with this patient. So it is not just science. Because same drug acts differently for different. So that is why if it acts in the same way for the same people, same dose, then it's a science. If it acts differently, you have to learn art only. So whatever it is both art and science. How you behave with the patient is very important. Most of the attacks for doctors can be minimized by the patient-doctor relationship. So coming back to that, so that is it. Some people feel not that technology is not important, it's very important. Without talking to the patient, only looking at the matter going on. It is like our children, they will be doing all this computer business. They won't even look at you. So that is human behavior is not there. Somebody and high technology. So for a doctor, how does he look at this high technology? He has superstitious uses it because he doesn't want to miss a single case. Superstitious. And it also prestigious doctor. So he doctor sees can get another doctor will do. So he feels bad. So prestige in the doctor. And then insurance, okay. And ethical, legal. Suppose by chance there is a tumor to this, you may be they can put a case against you. So that's called a defensive medicine. So to safeguard yourself in America, any headache, some headache and all that, they do not miss a single investigation. CT scan is very, very, very done, but that goes cost of your cost of health department, cost of management. That is why Hillary, they are all against this American way of medicine, where those who have been in America, how costly it is, because unnecessary things are done. Unnecessary things are why he has a defensive medicine. If a patient is carried in an ambulance, behind the ambulance, lawyer will go. Ambulance chases their cars. They go behind they go, and they catch hold of the system. Is there any deficiency in the treatment? Just catch and put a case. So the ambulance chases their cars. So what I am trying to say is defensive medicine is sometimes helpful, sometimes it can be not right. So how does society look at this? High technology facility has to be provided. But the problem is low technology, most of your 80% of your cases can be done with low technology, a general physician or family doctor who can work. This is what you see in England. Family doctor, this one. They will make up most of your cases. Where there is a problem, you refer. So low technology facility, you can do it for a large number. As from a government angle, you spend more on that. That is a mistake these people are doing. You open some 10 centers of Jarewa, that how many people are benefited? But if you open 10, hundreds of centers of primary health centers, primary health centers they are not active, they are not staffed. You pay the doctor much more, not 10,000, 50, give them 20, 30. They go and stay there. Primary health center is spent, then that doesn't mean government should not encourage high technology. Have in Bangalore 4 centers, 5 centers, very good. Now every nursing home, it's more than a nursing home, you have a high tech. The problem is expenditure. The government is difficult. So government policy is different. Government policy, they must spend more on primary education, primary health care, and of course there must be a high-tech hospital. There are not, but few, and equip them well. That is what we have to do. That is how society looks at it. Now after learning all these few things about high-tech medicine, how we can derive maximum benefit from this high-cost medicine? Now cost reduction has to be done. How it could be done? If you don't, good. Last one. So cluster, when you don't do unnecessary CT scans, etc., and ineffective investigation may be avoided. Suppose you are asking for a CT scan. Don't ask for a skull X-ray first. That's a waste. If you are going to have a CT scan. So all those ineffective investigation may be avoided. How else you can get the maximum benefit? The government can have few centers of high technology, so numbers. And most important, a rational and appropriate use of technology by doctors. Rational and appropriate use. Yes, we have 2 questions when you ask for it. Does it help your diagnosis? Does it help the patient in the treatment? 2 questions you have to ask. If it is going to help in the diagnosis, go ahead. If it helps in the treatment of this, go ahead. If you ask these two questions, 50% of your investigation is unnecessary. I am not saying high technology is very useful things. Things which are not seen or seen now. But ask these two questions. So, rational and appropriate technology. What is inappropriate? When it is unnecessary. When it is unsuccessful. Suppose a cancer patient with too many spread all over the body. Why do you want to investigate CT scan, chest scan, PET scan, all scans? You are not going to do anything. It is spread all over the body. So it becomes unsuccessful and it's unsafe, unkind, unwise. If you do not use this technology for these cases, then you can minimize this high technology and maximize its use. That is the main point. Yeah. So, in conclusion, next. In conclusion, you must know the challenge for the medical profession of this high technology. High technology is in every field, engineers, software, everybody will have. But as far as they are concerned, the challenge is to weigh the benefits versus the burden. It's very important. But some of us doctors, like a motorist, if he gets a new car, he would like to have the car immediately and see how it does and all that. And then, if there is something to repair, replace the part. But human body is not like that. So there's a difference in human body. So, and you must always, when you ask for a high-tech thing, patient-reduced participation is also very important. And whether many a time, what happens is that an emergency patient comes, then you have no time to think, then high technology is really useful. Then we have to go straight away to high technology, get things. That's a very important thing. So always I again ask, when a doctor orders for the high-tech medicine, you must ask two questions. Does it help in the diagnosis? Does it help in the treatment? Then there is the art of drawing sufficient conclusion from insufficient premises. That is the problem with medicine. Thank you.
Good evening, ladies and gentlemen. It's our fortune to have a wonderful talk on high-tech medicine, boon or burden. It has been very informative and educative, sir. On behalf of Bangalore Science Forum and all of us here, I propose vote of thanks to Dr. Tomorrow's talk by Sri Shara, Professor, International Institute of Information Technology, Bangalore, will be speaking on services, science and services computing. All are cordially invited. Now the session is over for please consultation.
Yes.
Subsequent memory loss of brain and the mind loss of brain, but mind functions. Please repeat your question once more. ICU, cardiac arrest can take place, and subsequently memory loss and mind part of brain is memory and brain part is damaged, but mind brain is still functioning. ICU didn't happen. Is it good? Negligence are natural.
You are lucky if you have a cardiac arrest in the ICU, not in the hospital. Because the instrument is there. Commonest cause of cardiac arrest is the heart
beats about 200 to 300 times like this. Ventricular fibrillation. If you are there, doctor concerned is there is a shock instrument, immediately give a shock, it reverses. The time taken from the arrest to reverse is very important. If you do it immediately, no brain damage occurs. If you take a longer time, there's going to be some brain damage. That will be there. I had a very experience, plus mine is nearly 40-50 years experience. I had 3 cases I remember. One is my high schoolmate from here only, who had a heart attack. He was in ICU. I had gone there for something. In front of me, his heart stopped. So I was there only. I could give him a shock and recover. And he survived another 10 years. And he died of lung problem, then heart shock. So this is a luck. Even if it is in the hospital sometimes, by the time you get out, it takes time. Quicker you do, less damage will be. I think that is your question, I understood. Right. So I had 2-3 cases, still another 2 are living, whom they survived about 8 years ago. Luckily I was there. Of course, it was in the ICU. What happens is, if it is a ward, by the time you get all these things, it takes time. May be damaged, may not be. It depends. Right.
ಸ್ಟೆನ್ಸ್ ಟ್ರೀಟ್ಮೆಂಟ್ ಅಲ್ಲಿ ನೀವು ಹೇಳಿದ್ರೆ ಅವಾಗ ಏನ್ ಮಾಡ್ತೀವಿ ಅವಾಗ ಪೇಷಂಟ್ಗೆ
ಕಿಡ್ನಿ ಥ್ರಾಂಬೋಸಿಸ್ ಆದ್ರೆ ಯಾವುದು ಕಿಡ್ನಿ ರೀಸ್ಟೆಂಟ್ ಮಾಡಬೇಕು. ಇಫ್ ಇಟ್ ಇಸ್ 2-3 ವೆಸಲ್ಸ್ ಬೈಪಾಸ್ ಮಾಡಬೇಕಾಗುತ್ತೆ. ಅದೆಲ್ಲ ಆಗದಾಗೆ ಎಕೋಸ್ಪೆರಿನ್ ಆಸ್ಪಿರಿನ್ ಎಲ್ಲ ಕೊಡ್ತೇವೆ. ಬಟ್ ಈವನ್ ದೆನ್ ಇಫ್ ಇಟ್ ಇಸ್ ರೀಥ್ರಾಂಬೋಸ್, then what happens is you can remove the clot, put another stent also. Or if you 2-3 vessels are blocked at that time, they do angiogram, then you do a bypass. If it is still one vessel, you can remove the clot, put modern stents are costlier as well as probably earlier metal stent used to last for 2-3 years, some thrombosis is to occur. Now you have got drug-eluting stent that will 5 years, 4 years. Now I think tissue stents are coming, yes. So you got not that at the end of the day, we can still do something.
Blocks in that. That is my first question. Next is the robotic surgery. Indiaದಲ್ಲಿ robotic surgery ಇದೆಯಾ ಅಂತ?
Robotic surgery in the ಮಣಿಪಾಲದಲ್ಲಿ ಒಂದು section open ಆಗಿದೆ. Not for all. All is this technical. All got removal one is there.
An accurate
surgery. Even this stent and now the first question, what did you ask?
Angiogram.
Accuracy.
They want to meet the expenses
No,
of the instrument.
no.
So they say 3 blocks ಇದೆ ಮಾಡಿ.
No. First question, do you need an angiogram? Why do you need? If you have gone for a chest pain, which is not reviewed by this one, ECG does not show, you are not sure what it is, you go for an angiogram. There will be blocks in different 30%, 40%, 50%. You need not put a stent or a bypass 30, 40%. 60% above you have to see. Whether drug is enough, you have to see. All those things. Angiogram is the same. No, that's why angiogram originally, you do it from then the catheter goes up to the heart and then you inject. Now you have got percutaneous. You inject here only the inhaler thing and you can get an angiogram of the heart. There is that now.
My question, renal disease case, in the renal disease case, I saw this lead and you were also telling that the 2 kidneys, the failure kidneys were left as it is and the new kidney will be transplanted. So the failure kidneys won't make any problem in future to the patient?
No kidneys are dead.
Yeah.
They are there only.
Yes.
So one kidney.
Yes, sir.
So one kidney.
So, but the other failure 2 kidneys, they won't remove from the man's body.
There is no, they won't rebirth.
They won't function and nothing will happen.
Okay, there is no problem.
Thank you, sir.
So that is 2 are dead. Okay. So even but they don't. Doctors do not disturb those 2 kidneys. They keep the transplanted kidney in the roll down.
Cell function is there.
No function. Practically no function. Before transplanting, I make sure there is no function.
What is the difference between the patient in coma state and brain death patient, sir? Coma state patient ಹೇಗೆ ನೀವು ಇನ್ವೆಸ್ಟ್ ಮಾಡ್ತೀರಾ?
ನಾನು ಹೇಳಿದ್ರು ಸರ್ ಕೋಮಾ ಸ್ಟೇಟ್ ಅಲ್ಲಿ ಇರೋದು ಮತ್ತೆ
ಬ್ರೈನ್ ಡೆತ್ ಆಗಿರೋದು
ಬಟ್ ಬ್ರೈನ್ ಡೆತ್ಗೂ ಕೋಮಕ್ಕೂ ದಿ ಅದರ್ ಫೀಚರ್ಸ್ ಆರ್ ದರ್. ಪ್ಯೂಪಿಲ್ ನೋಡ್ತೇವೆ, ವೆದರ್ ಈಸ್ ಕಾನ್ಶಿಯಸ್, he can come back. If it's a temporary coma, brain dead, he will never recover. ಕೋಮಾ ಆದ್ರೆ ಈಗ ಇದು ಶುಗರ್ ಲೋ ಆಗಿ ಕೋಮಾ ಆಗುತ್ತೆ. If you give glucose, they come. Coma does not. Coma means only unconsciousness. It is not a permanent unconsciousness. Brain dead means unconsciousness. ಒಂದು ಲೇಡಿ 6 ತಿಂಗಳು ಇಟ್ಕೊಂಡಿರ್ತಾರ ಅಂದ್ರೆ ಇದು ಯೂಸ್ಫುಲ್ ಟು ಎಥಿಕಲ್ ಪಾಯಿಂಟ್ ಈಸ್ ಸಪೋಸ್ ಇಸ್ ಎ ಬ್ರೈನ್ ಡೆಡ್ or coma, if they are 6 months or that, brain dead only. If that is the case, is it correct to go on continuing with that sort of life? There was one nurse in Bombay, 6 months or so. Is it correct? But according to legally, India has not got at all. India you can't have a euthanasia at all.
ನಮಸ್ಕಾರ ಸರ್. ಸರ್, ಇದು ಯುಥನಾಸಿಯಾ ಇಸ್ ನಾಟ್ ಅಲೌಡ್ ಇನ್ ದಿಸ್ ಕಂಟ್ರಿ ಅಂತ ಹೇಳಿದ್ರೆ, ಆದ್ರೂ ಇಲ್ಲಿ ಕೆಲವರು ಪೇಷಂಟ್ಸ್ ಯುಥನಾಸಿಯಾ ನಾಟ್ ಅಲೌಡ್ ಅಂತ ಹೇಳಿದ್ರಿ. ಬಟ್ ತುಂಬಾ ಕೆಲವು ಜನರು ಎಲ್ಲರೂ ಅಂತ ಹೇಳಿಕಲ್ಲ ಮಿಸ್ಯೂಸ್ ಮಾಡ್ಕೋಬಹುದು. ಆದ್ರೂ ಕೆಲವರಿಗೆ ಅದು ಅವಶ್ಯಕತೆ ಇರುತ್ತೆ. ಆ ಕಡೆ ಬದುಕಲಿಕ್ಕೂ ಆಗೈತಿ, ಸಾಯ್ಕ್ಲು ಆಗದೆ ಸುಮ್ಮನೆ ಸಫರ್ ಆಗ್ತಾ ಇರ್ತಾರೆ ಎವ್ರಿ ಟೈಮ್ ಎವ್ರಿ ಮಿನಿಟ್. ಅಂತ ಪರ್ಸನ್ಸ್
ಹೇಳಿ
ಅಂತವ್ರಿಗಾದ್ರೂ ಪರ್ಮಿಷನ್ ಕೊಡ್ಲಿಕ್ಕೆ.
Question is, there are two things, ethical and legal. Ethical ಆಗಿ ಅವನು ಪೇಷಂಟು ಏನು ಪ್ರಯೋಜನ ಇಲ್ಲ, ಬ್ರೈನ್ ಇದೆ ಅಥವಾ ಲಂಗ್ ಕಾಯಿಲೆ ಇದೆ, ಗುಣ ಆಗೋ ಕಾಯಿಲೆ ಇಲ್ಲ ಅಂಥದ್ದೆಲ್ಲ ವೆಂಟಿಲೇಟರ್ ತೆಗೆದು ತಿರುಗಿ ವೆಂಟಿಲೇಟರ್ ಹಾಕಬಾರ್ದು, ಪರ್ಮನೆಂಟ್ ವೆಂಟಿಲೇಟರ್ ಹಾಕ್ತದೆ. ದಿ ಕ್ವಶನ್ ಇಸ್ ಕಾಸ್ಟ್. ಕ್ವಶನ್ is not going to get cured, incurable disease. ಅಂತವರಲ್ಲಿ ಕರೆಕ್ಟ್ ಆಗಿದ್ರೆ ಯುಥನಾಸಿಯಾ ಎಥಿಕಲಿ ಕರೆಕ್ಟ್. ಬಟ್ ನಮ್ಮ ದೇಶದಲ್ಲಿ ಅಥವಾ ಮೋಸ್ಟ್ ಆಫ್ ದಿ ಕಂಟ್ರೀಸ್ ಅದನ್ನು ನಾಟ್ ಲೀಗಲಿ ಅಲೌಡ್. ಅದಕ್ಕೆ ಆದರೆ ಹೆಚ್ಚಿನ ಕಾಲದಲ್ಲಿ ಏನಾಗುತ್ತೆ ಅಂದರೆ ಇದನ್ನು ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡಿಬಿಟ್ರೆ ಪೇಷಂಟ್ಗಳಿಗೆ ರಿಕವರ್ ಆದರೂ ವೆಂಟಿಲೇಟರ್ ಬೇಕಾಗುತ್ತೆ ಅದನ್ನು ಹೇಳ್ತಾರೆ. ಇಫ್ ದೇ ಅಗ್ರಿ ಒಂದು ರೈಟಿಂಗ್ ಸಪೋರ್ಟ್, ಬಟ್ ಲೀಗಲಿ ಕ್ವಶನ್. ಸೊ ethically what we are talking is correct. Incurable disease, suffering from pain, and we are not able to control the pain. Incurable disease, patient's relatives feels better, he goes, dies, then passive euthanasia is correct. You withdraw oxygen, withdraw ventilator, all. Ethically correct. Legally in India. In India only Holland and few states in the United States there are. ಯಾಕಂದ್ರೆ ನಾಳೆ ಯಾರಿಗೆ ಗೊತ್ತು ಡಾಕ್ಟ್ರೇ ಒಬ್ಬ ಟೆರರಿಸ್ಟ್ ಆಗಿದ್ರೆ, ಯು ಡೋಂಟ್ ನೋ. ಸಮಟೈಮ್ಸ್ ಯು ವಾಂಟ್ ಟು ಕಿಲ್ ಎ ಪರ್ಸನ್, ಸಮಥಿಂಗ್ ಲೈಕ್ ದಿಸ್ ಯು ಕ್ಯಾನ್ ಚೆಕ್. ಅದಕ್ಕೋಸ್ಕರ ದೇ ಆರ್ ವೆರಿ ಹೆಸಿಟೆಂಟ್ ಟು ಇಂಟ್ರೊಡ್ಯೂಸ್.
ಸರ್, HbA ಪಾಸಿಟಿವ್ ಬಂದ್ರೆ ಏನು ತೊಂದರೆ?
HbA ಅಂದ್ರೆ ಹೆಪಟೈಟಿಸ್ ಬಿ ಇನ್ಫೆಕ್ಷನ್. ಅದು 2 ತರ, ಒಂದು ಜಾಂಡಿಸ್ ಗೀಂಡಿಸ್, ಒಂದು ಟಕ ಬರ್ತದೆ, ಇನ್ನೊಂದು ಹಾಗೇ ಇರ್ತದೆ ಕ್ವೈಟ್ ಆಗಿ. ಯು ಕ್ಯಾನ್ ಸ್ಪ್ರೆಡ್ ದಿ ಡಿಸೀಸ್. ನಿಮ್ಮ ಬ್ಲಡ್ ಇನ್ನೊಬ್ಬರಿಗೆ ಕೊಟ್ಟರೆ ಅವರಿಗೆ ಕೊಡ್ತದೆ. ಆದ್ರಿಂದ ಬ್ಲಡ್ ಟ್ರಾನ್ಸ್ಫ್ಯೂಷನ್ ಮಾಡುವಾಗ ನೀವು HbA ಪಾಸಿಟಿವ್ ನೋಡ್ತಾರೆ, ಇನ್ನೊಬ್ಬರಿಗೆ ಬ್ಲಡ್ ಕೊಡುವಾಗಿಲ್ಲ. ಸೆಕೆಂಡ್ಲಿ ಸೆಕ್ಷುವಲ್ ಆಕ್ಷನ್ ಇದರಲ್ಲೆಲ್ಲ ಯು ಕ್ಯಾನ್ ಸ್ಪ್ರೆಡ್ ಟು ಅನದರ್ ಪರ್ಸನ್. ಥರ್ಡ್ಲಿ ಇದು ಸ್ಪ್ರೆಡಿಂಗ್. ನಿಮಗೆ ತೊಂದರೆ HbA ಪಾಸಿಟಿವ್ ಇದ್ದವರಿಗೆ ತೊಂದರೆ ಇದ್ರೆ ಆ ಲಿವರ್ ಸಿರೋಸಿಸ್ ಆಗ್ಬೋದು, ಲಿವರ್ ಟ್ಯೂಮರ್ ಆಗ್ಬೋದು.
ಮೆಡಿಸಿನ್ ಇಲ್ಲ ಸರ್, ಇಟ್ ಇಸ್ ನಾಟ್ ಮೆಡಿಸಿನ್ ಇಲ್ಲ ಸರ್.
ಟ್ರೀಟ್ಮೆಂಟ್ ಅವೈಲೇಬಲ್.
ಮೆಡಿಸಿನ್ ಈಸ್ ಅವೈಲೇಬಲ್. ಟ್ರೀಟ್ಮೆಂಟ್ ಅವೈಲೇಬಲ್.
ಮೆಡಿಕಲ್ ಮಿರಾಕಲ್ಸ್ ಅಂತ ಕೆಲವೊಂದು ಮೆಡಿಕಲ್ ಮಿರಾಕಲ್ಸ್ ಅಂತ ಈಗ ಡಾಕ್ಟರ್ ಹೇಳಿದ್ರೆ ಬದುಕೊಂಡ್ಬಿಡ್ತಾರೆ. ಅದಕ್ಕೆ ಸಾಧ್ಯ
ಬದುಕಿದ ಪೇಷಂಟ್ ಡಾಕ್ಟರ್ ಕ್ಯಾನ್ಸರ್ ಹೇಳಿ ನೀವು ಬದುಕೋದಿಲ್ಲ ಅಂತೆಲ್ಲ ಡೆತ್ ಸರ್ಟಿಫಿಕೇಟ್ ಪಾಸ್ ಮಾಡಿದ್ದೆ. ಅವನು ಬದುಕಿದ್ರೆ ಅದು ಕ್ಯಾನ್ಸರ್ ಅಲ್ಲ,
ರಾಂಗ್ ಡಯಾಗ್ನೋಸ್
ರಾಂಗ್ ಡಯಾಗ್ನೋಸಿಸ್ ಹೇಳ್ತೇನೆ. ನಾನು ಬಳ್ಳಾರಿಯಲ್ಲಿದ್ದೆ. ಒಂದು ಪೇಷಂಟ್ ಇದ್ದ, ಒಂದು ಲಂಗ್ನಲ್ಲಿ ಒಂದು ಟ್ಯೂಮರ್ ತರ ಇತ್ತು. ಎಲ್ಲ ನ್ಯೂಮೋನಿಯೂ ಆಗ್ತಿತ್ತು. ಆಂಟಿಬಯೋಟಿಕ್ ಎಲ್ಲ ಕೊಟ್ಟೆ, ಇಂಪ್ರೂವ್ ಆಗಲೇ ಇಲ್ಲ. ಆ ಟ್ಯೂಮರ್ ಅದೇನು ಸ್ವೆಲ್ಲಿಂಗ್ ಇದೆ ಸ್ವಲ್ಪ ದೊಡ್ಡದಾಗಿತ್ತು. ಅದು ಅವಾಗ CT ಸ್ಕ್ಯಾನಲ್ಲಿ ಇರಲಿಲ್ಲ. ನನಗೆ ನ್ಯೂಮೋನಿಯಾ ಅಂದರೆ ಆಂಟಿಬಯೋಟಿಕ್ ಕೂಡ ಆಗಬೇಕಿತ್ತು. ಅದು ಹಾಗೇ ಇದೆ, 1 ತಿಂಗಳಾದ್ರೂ ಹಾಗೆ ಇದೆ. ಆಮೇಲೆ ಕಡೆಯವರಿಗೆ ಹೇಳಿದೆ, ಯಾಕೋ ಸರಿ ಇಲ್ಲಪ್ಪ, ಇದು ಟ್ಯೂಮರ್ ಇರೋ ಚಾನ್ಸಸ್ ಇದೆ, ಮನೆ ಕರ್ಕೊಂಡು ಹೋಗಿ ಅಂತೆ. 1 ತಿಂಗಳಾದ್ಮೇಲೆ, 1-2 ತಿಂಗಳಾದ್ಮೇಲೆ ಅವನು ಇನ್ನೊಂದು ಪೇಷಂಟ್ ಕರ್ಕೊಂಡು ಬಂದ. ಆವಾಗ ನಾನು ಏನ್ ಮಾಡಿದೆ ಅಂದ್ರೆ, ಈ ಆಂಟಿಬಯೋಟಿಕ್ ಅಲ್ಲಿ ಬಿಟ್ಟು ಹಳೆ ಕಾಲದ ಒಂದು ಸ್ವಲ್ಪ ಹಾಕಿ ತಿಂಗಳ ತಗೋಪ್ಪ ಅಂತ ಹೇಳಿ ಕಳಿಸ್ಬಿಟ್ಟೆ. ಆಮೇಲೆ 1 ತಿಂಗಳಾದ್ಮೇಲೆ ಅವ್ನು ಬಂದ, ಇನ್ನೊಂದು ಪೇಷಂಟ್ ಬೇಕು. ನನ್ನ ಸಾಷ್ಟಾಂಗ ನಮಸ್ಕಾರ, ಅಷ್ಟು ಚೀಪ್ ಮೆಡಿಸಿನ್ ನಲ್ಲಿ ನಾನು ಇದು ಗುಣ ಮಾಡಿಬಿಟ್ಟೆ ಅಂತ. ನಾನು ಎಕ್ಸ್ರೆ ಶಾಲೆ ಹೋಗ್ಬಿಟ್ಟಿದೆ. ಪ್ರಾಬ್ಲಿ ರೆಸಿಸ್ಟೆಂಟ್ ನ್ಯೂಮೋನಿಯಾ which responded to the older drugs than the present modern drugs. ಅಲ್ಲಿ ಏನಾಗಿದೆ, ರಾಂಗ್ ಡಯಾಗ್ನೋಸಿಸ್. ಅವನು ಇನ್ನೊಂದು ಪೇಷಂಟ್ ರೆಕಮೆಂಡ್ ಮಾಡ್ತಾರೆ.
ಕೆಲವು ಕೇಸಲ್ಲಿ ಏನು ಕೊಡಕ್ಕೆ ಸ್ಟೀರಾಯ್ಡ್ಸ್ ಕೊಟ್ಬಿಡ್ತಾರೆ. ಬಚಾವ್ ಆಗ್ಬಿಟ್ಟು ಚೆನ್ನಾಗಿ ಬದುಕೊಂತ ಇರ್ತಾನೆ ಅವನು. ಆದ್ರೆ ಎಫೆಕ್ಟ್ ಆಗುತ್ತೆ ಒಂದು ಹೇಳ್ತಾರೆ, ಅಡ್ಜಸ್ಟ್ ಆಗ್ಬಿಡುತ್ತೆ ಸ್ಟೀರಾಯ್ಡ್ಸ್ ಕೆಲವು ಬಾಡಿಗಳು.
ಸ್ಟೀರಾಯ್ಡ್ ಸಿಂಪ್ಟಮ್ ಸಪ್ರೆಸ್ ಮಾಡುತ್ತೆ ಟೆಂಪರರಿ, ಗೊತ್ತಾಯ್ತಾ?
ಫೈನಲ್ ಅಲ್ಟಿಮೇಟ್ ಡೈ
ಈಗ TB ಇದ್ದವರಿಗೆ ಸ್ಟೀರಾಯ್ಡ್ ಕೊಟ್ರೆ, TB ಔಷಧಿ ಕೊಟ್ರೆ TB ಕ್ಲಿಯರ್ ಅಪ್ ಆಗುತ್ತೆ. ಸ್ಟೀರಾಯ್ಡ್ ಒಳ್ಳೇದೇ ಮಾಡೋದ್ರೆ ಕೆಟ್ಟದ್ದು ಮಾಡ್ತದೆ, ನಿಮ್ಮ ಬಾಡಿ ರೆಸಿಸ್ಟೆನ್ಸ್ ಕಡಿಮೆ ಮಾಡ್ತದೆ. ಇನ್ಫೆಕ್ಷನ್ ಇರೋವರಿಗೆ ಸ್ಟೀರಾಯ್ಡ್ ಕೊಟ್ರೆ ಇನ್ಫೆಕ್ಷನ್ ಇನ್ಕ್ರೀಸ್ ಆಗುತ್ತೆ, ಗೊತ್ತಾಯ್ತಾ? ಸೊ ಕೆಲವು ಕಾಲರಿಗೆ ಸ್ಟೀರಾಯ್ಡ್ ಇದೆ.
ಲೈಫ್ ಲಾಂಗ್ ಕೊಟ್ಬಿಟ್ಟಾಗ ಏನಾಗ್ಬೋದು ಕೊಡ್ತಾರೆ ಕೆಲವು ಕೇಸಲ್ಲಿ. ಸರ್ ಈಗ ಇಮ್ಯುನೋಡಿಫಿಷಿಯನ್ಸಿಗೆ ಲೈಫ್ ಲಾಂಗ್ ತಗೊಳ್ಳೋದು. ಇಮ್ಯುನೋಡಿಫಿಷಿಯನ್ಸಿ ಡಿಸೀಸ್ಗೆ ಇಮ್ಯುನೋಡಿಫಿಷಿಯನ್ಸಿ
ಡಿಸೀಸ್ ಲೈಫ್ ಲಾಂಗ್